It is a medicine that is unlike others, in that, from a patient perspective, um, patients will not have had a drug like it. It's a subcutaneous injection. It is an injection that, as you've been discussing, has to be given by a healthcare professional, usually a qualified nurse with chemotherapy experience, because it's classed as a chemotherapy drug, but it's not really a chemotherapeutic agent in the way many others are. And it's been the bedrock of treatment for many patients with MDS over 2 decades now. The aim of the medicine is to extend life. The aim of the medicine is to improve quality of life, to reduce the need for blood transfusions, to reduce the need for platelet transfusions, and to reduce infections and hospital stays that come from having infections. It's a medicine that is used for patients with MDS of a higher risk category, but this may mean something to some of you. It may not mean a lot to others, but it's that form of MDS where there are already some features that suggest that it's of a higher risk of progression to acute myeloid leukemia. And so therefore, to retard that progression and to improve survival, improve quality of life, azacitidine is used as a first-line treatment. It is a treatment that doesn't work in everybody. It's a treatment that approximately will work in about half the patients that it's administered to. It's a treatment that takes time. It won't work straight away. On average, the first inklings of a response come after about 3 months of treatment. And we usually give patients at least 6 months of treatment before we say it's either working or not working. 90% of all patients who are likely to respond will do so within 6 months. It's given in hospital as an injection typically on 7 days, typically on a Monday to Friday, and then a Monday, Tuesday. So the weekend, patients don't have the injection, and it's typically given every 28 days. This restricts life for patients because it means that they need to come back to hospital to have these injections. In the beginning, at any rate, we tend to keep a very close eye on a patient's blood and their general well-being, just to make sure that they're coping with the injections properly. And if they need additional blood transfusions or platelet transfusions, or just monitoring their blood and their well-being, we tend to keep an eye on people even in the weeks between injections. Once patients are stabilized on the injections, generally they tend to come just for the period of time that they have injections, especially if they're responding well. There are side effects, like with all medicines, and the side effects include having a rash, and it can look particularly angry at the site of injection. But this is usually not painful. Usually avoid the area where a belt or buckle or whatever would be in the midriff, usually given in the tummy area, but can be given in the upper parts of the limb as well. And if it is a bit angry or a bit sore, then typically oil of evening primrose or St. John's wort from Holland and Barrett or wherever can calm the skin down. It is the rare patient for whom that skin reaction is so bad that they feel they can't have those injections. All patients will be nauseous on azacitidine unless they take an anti-sickness medicine on the morning of the injection. So prescription of an anti-nausea agent is standard and should be taken on the days of injection, but typically not afterwards. People can lose their sense of taste or have altered taste. People generally find that their appetite is a bit dimmed on injection days. And some people can get constipated mainly from the anti-nausea medicine. So playing around with that anti-nausea medicine is quite important if that is a concern. In addition to that, the most important side effect is that the blood gets worse before it gets better. So typically in the first couple of months, a patient may need more blood transfusions, more platelet transfusions. They may be at a higher risk of infection, and they may indeed have to come to hospital because of an infection. But if the blood responds, and it's usually the platelet count that goes up first, this then all settles down. This is a very medical view of having azacitidine. And in reality, it's a little bit different for every patient. The nursing staff, in whichever hospital your azacitidine is being administered, are true experts because they spend so much time with the patient, talking to the patient, talking to many patients about what their day is like, what their days are like, and how the treatment affects them. So I want to take this opportunity to really ask Claudia, who has given azacitidine to many patients and talked to many patients, what her experiences are of what patients say. Claudia.
Thank you. So in general, my experience with patients is that azacitidine is a very well tolerated drug. The main issue being the rash. The nausea is usually very well managed with the anti-sickness on the day of the injection. I would say probably the part that patients find the hardest is the coming into a hospital daily for that week of the cycle. That is not as much drug reaction to the drug, but just the way that the regimen or the cycle works. Patients tend to say that they feel a little bit tired probably the week after the injections, but that in general it's well tolerated and it allows them to continue with their day-to-day life. And actually that not being the case is the very rare exception.
It would be really helpful and important for both Claudia and I to hear what you think, and to hear what, if you have had azacitidine, what your experiences are, or if you're about to start azacitidine, what you've been told about it, and if you have any questions, please do ask.
One of the first questions, my sister has MDS and is in her 70s and wanted to know about the relative efficacy of azacitidine for somebody in her age group. I mean, interestingly, because most people with MDS are in their 70s, I would guess that this is a very common age group, but yeah, maybe if Prof. Vyas can comment on that.
Sure. So azacitidine works equally well in all age groups. It's not, it doesn't care what your age is, whether you're 90 or 80 or 70s or 60s, what have you, 50s, it will work equally well and in all ages.
Well, that's good to know. You've touched a bit on the side effects, and from what Claudia said, they are mainly tolerable, with perhaps evening primrose oil playing a role in making it more easy to tolerate. Is the sort of the level at which patients tolerate it, does that grow with the number of treatments, or is it you're either going to have side effects or you won't throughout?
Sure. So the first thing to say is that over the years, I've had the privilege of looking after, I would say, hundreds of patients on azacitidine. And of course, through my colleagues, I've come to hear about many more. And it is the rare patient, genuinely, it is the rare patient who, for very good reasons, will say, I really can't have this medicine. So the vast majority of patients do have it. That's not to say that all of them are thrilled to be on it. Most of us would rather be not on anything, I think. So let's just put it in context. But that said, the benefits outweigh the problems. Claudia's asked a very specific question, which is, does it become more tolerable with time? My experience is people learn to build their lives around it. The hassle is putting somebody out to bring you to hospital if you can't come on under your own steam. The hassle is waiting for hospital transport, which can be a real kind of pain. Usually once you're in hospital and you're in your day unit, certainly in Oxford, I can speak to this, you're very thrilled to be with people who know you, look after you. You've got to know them, you've established a relationship, you feel safe. And there are usually other individuals, other patients who come on the same day as you. And it's a bit of a, there's a social element to it, shall I say. And so that is important. And, patients will swap stories and, tell their anecdotes about AZA, and some of them will be very helpful. Some people genuinely, we've talked about rash, we've talked about hospital admission for infection. Some patients genuinely do struggle with altered taste. Some do struggle with diminished appetite. I don't know of a good way around that. I don't think that becomes more tolerable with time. Some people are more fatigued and know that they've had an AZA week the week before. It's not a normal week for them. But the week after, they feel really good. And that is a pattern often people will get into. This does put a limit on holidays and, time you can have. But to be absolutely clear, you don't need to be rigid about that 28-day cycle. So there is flexibility, and we are certainly very flexible about, having an additional week. For example, if it fits with family holidays or family occasions or what have you. Of course, there's flexibility around Christmas and New Year and all that. So there is flexibility. A week here or there isn't really going to make a big difference. The other thing I would say is, for some people, they prefer to do a 4 and 3, not a 5 and 2. So they'd rather start on a Tuesday instead of a Monday, and then go Monday, Tuesday, Wednesday the following week. All manner of variation is possible, as long as it works for you and the team looking after you. Does that answer some of the points you raised, Claudia?
Yes, I think that does. Thank you. And the next question is azacitidine appropriate for crossovers such as MDS/MPN?
That's a great question. So the clinical trials have primarily been done with MDS patients. The clinical experience is primarily with MDS patients. It has been used in patients who have had a condition called chronic myelomonocytic leukemia, CMML, which is a kind of hybrid between MDS and a condition called myeloproliferative disorders, or MPD. My sense is, if I had a patient in front of me, I would use it for that group of patients. Indeed, it is licensed for CMML2, the original license of the drug. Would I be as confident that 50% of these patients would respond? Probably less so, just because less patients have been treated with that condition. But I would be hopeful for a response, because otherwise I wouldn't give it.